post-traumatic growth is a natural response of a lot of people who are living with this kind of fit cancer. Stress is more a normal response to an abnormal situation. Broad scope is related with how we can be engaged in our lives.
Hello everyone, nice to meet you again to a new episode from Beyond the Cancer Diagnosis interview series. Today is my pleasure to present you Dr. Cristian Ochoa. He is Psych-Oncologist at the Catalan Institute of Oncology, also Professor of Psychology at University of Barcelona. Dr. Ochoa, Cristian, thank you very much for accepting my invitation.
Thank you, good morning, and it's a pleasure to be here with you, Adrian.
And together with Dr. Ochoa, we'll approach a concept very interesting in psych-oncology, positive psychotherapy in cancer, and with the main question, how positive should a cancer patient be at the end of these discussions? We'll try to figure out. But for the first question to begin our discussion, I would like very much Dr. Ochoa to develop this concept and the main aim of this positive psychotherapy in cancer.
Okay, thanks, Adrian. First of all, cancer patients didn't need to be positive. Positive is not a mandatory tyranny that people have to maintain in such an adverse situation. Positive it's sometimes the way that we explain in a popular way how to find our best version, how we can live fully live in this situation. But it's not a mandatory, it's not a kind of tyranny of, and then patients, it's a kind of natural response. As you say, post-traumatic growth is a natural response of a lot of people who are living with this kind of fit cancer. And that's the thing. We begin to study cancer in this kind of two main processes that are really involved in this situation, stress and growth. And stress and growth are very connected concepts and connected response in cancer. But in the past, we are very focused in the suffering part of this duality, in the stress. But we know a lot of this other part, post-traumatic growth, which in a simple way is positive vital changes that people could explain after cancer. And now we know a lot of this positive growth response, and positive psychotherapy is the way that we are trying to put in clinical settings all this knowledge related with positive vital change that has a lot of potential in the adaptation of patients in cancer. And this was our research previously to define positive psychotherapy in cancer.
And when you start this project?
A positive psychotherapy is a kind of life project, and it begins at 2020. It's 2010, where we published the first draft of the positive psychotherapy program in Spanish, and 3 or 4 years after, we published the same program with little changes in English in a comprehensive guide. Then we are working in this field around 15-20 years.
I was asking this because you mentioned post-traumatic growth, and also this theory, this concept, it's also new kind of new as a concept in the field of psych-oncology. Of course, post-traumatic growth, it is a concept in other areas with history, but related to psychoncology, it is also a new concept. And I saw that you apply the principles of post-traumatic growth. And I want to ask you that when you are talking about post-traumatic growth as a scientist, professor, from a theoretical point of view, everyone is thinking to Dr. Tedeschi, Dr. Calhoun theory of post-traumatic growth. Of course, you use that also, but I know that you use also other, not theory, but other interpretation, to put it this way, of more European way of Dr. Joseph and Dr. Linley. Can you explain a little bit? There are differences in approach, or where is that line that make the difference?
Welcome is a kind of more specific. The difference are more related with a theoretical and application of these principles. But Kaufman and Tedeschi were the pioneers in this field in the United States, and also a lot of people are involved in this area because they began to do a very good job related with these positive life changes that people do in other situations, not only in cancer. But there are a lot of people also in Europe doing this work, and these other theoretical models has some peculiarities that I feel more comfortable with this. For example, Joseph and Linley explained in a more humanistic and existential way how we could approach this adverse situation. For example, I think Kaufman and Tedeschi also could think similar things, but the way that they explain it's different. For example, in Joseph and Linley model, stress is more a normal response to an abnormal situation. And a lot of our approaches trying to help people to understand what's happening, what are these reactions meaning in their lives. And these things, it's for me, it could be the main thing that it could be different. For Joseph and Linley, stress and growth are interpreted in the same human experience framework. And for me, it's interesting because, for example, they have developed instruments to assess stress and growth involving both processes. And they have their model, it combines very well stress and growth as a mechanism that could be that explain this other equilibrium that people have after this adverse situation. And perhaps this is, for me, the most important difference in these models. But of course, both of them are do explaining similar things, and the approach normally are similar. But for me, it's important because if we think that post-traumatic growth is in a kind of individual fight or war, or a kind of we need to be better in each moment, it's different that if we involve, for example, the other people around us, a more relational and community approach, then I always see in both in the United States and Europe, but I think it's more typical to see it in Europe if we think that post-traumatic growth is not an individual approach, it's a kind of relational work with our caregivers, with the people that are surrounding us and supporting us during cancer.
I guess it's also a problem of cultural background at the end, because as we know, Professor Tedeschi and Calhoun developed post-traumatic growth for the veterans from US Army to help them pass the traumatic events. In Europe, as you mentioned, it's a more humanistic approach related to what the cancer patients feel, and to take it from point A to point B. It's a cultural background.
Yeah, of course, that's it. I agree with you that it's a kind of a cultural and it's different the way that they began to study post-traumatic growth in different adverse situations. When I have to talk about positive psychotherapy in cancer, one of the things that I explained at the beginning is that cancer is a different stressor. It's not this kind of acute stressor, and this changed a lot of the psychological response related with cancer. For example, one example is where is the threat or the reference of the threat in cancer? It's the future. It's what is death, is loss of autonomy, is suffering, and be a problem from my family in the future. But in other in other traumatic situations, the reference of my thread of my traumatic memories is the past. For example, in soldiers in Vietnam is what they live, not what is going to happen in the future. And this changed a lot how we can approach these situations, because we have to approach more the possibility to be in the future for patients with cancer, because cancer is an ongoing threat. It's a threat that is not restricted to a period of time, like acute stressors. It's involving your life perspective and how you can project yourself in the future. And your identity in the future it could be changed relative with this threat. And that changed a lot how to approach both things, stress and growth.
It's cancer. It's like a sinusoidal issues, because today you are feeling good, but tomorrow you are not feeling good, and you are asking why. So it is very important, as you mentioned, how you see yourself in the future, what is the further plans to deal with, and also, as you mentioned, cancer as a stressor.
Yeah, and another thing that is related to what you have mentioned, perhaps we need people a lot in cancer, because perhaps we are not, cancer could be invalidating in some moments, and you need more people, and how we work with this kind of needs. Because if the people around me responds good, I feel this kind of incremented connection with them. But if not, we need to work with this kind of potential damaging in our relations and forgiveness and something like that. No? That's one of the things that normally in acute situations also could appear, but normal it's different when the needs and the threat is maintained in time.
You mentioned about the patients and the very important relations with the patients, because if they don't give us as specialists feedback that we need, we have to start wondering what it's happened. And in order to facilitate these life changes, I know that you develop a program, a positive psychotherapy in cancer program. Could you tell us what is about the program, the structures, the issues, and especially the stages of this program?
Of course, but this program has the same idea of I mentioned, is we need to combine the negative changes in my life around cancer with these potential new areas that could be positive if we conduct well our experience in cancer. Then the program in a formal way are 12 weekly sessions around 90 to 120 minutes with 2 follow-ups at 3 months and 12 months after the end of the active psychological treatment. It's obviously focusing on humanistic existential approach, but with with a philosophy of cognitive and behavioral focus in each session. But the main idea is we are going to work with two processes: assimilation and accommodation. Assimilation is the way that, because it is important to mention that our program is validated with randomized controlled trials in people at the end of their primary oncological treatments, because we saw that these people are in a kind of what is happening now in my life. They are trying to return to their lives. Everyone thinks that and now they could be cured, but they feel that a lot of changes has passed and they need to assimilate all these changes and try to change also them to incorporate the things that cancer has questioned in their life. Then the most important thing is this positive psychotherapy program is their definition, and the best way that we can conduct this treatment is for people at the end of their oncological primary treatments. Then, in this point, we dedicate 4 or 5 sessions for a simulation process. Then we are going to talk at the beginning about what are the most difficulties things around cancer. We are not denying what is passing in cancer. We are not trying to see only the positive part of cancer. That is the right of the patient to see or not to see what are all the changes in their lives. But the first sessions are related with emotional expression, processing. We try to promote the vital awareness, curiosity, work with positive and negative emotions in the same way in sessions, trying to symbolize and resignificate these post-traumatic stress symptoms that normally appears in the first session in our positive growth psychotherapy, because we begin the program with what was your experience after cancer. They actualize and update all the problems that they have at the beginning of cancer. And we work with this negative or this not pleasurable symptoms. After this, in a simulation process, we talk about emotional expressing processing first. After, about emotional regulation and coping. We try, in the cases that symptoms are really high, we try to train with some relaxation, guided imagery, management of anger or irritability, sleep hygiene rules. But normally, it's not the most important area for us, because our idea is post-traumatic stress symptoms that has been updated in these first sessions of the program are normal reactions for an abnormal reaction. And our focus is try to find the function in their lives of these reactions. Then this first part is a part to reactivate all the negative impact of cancer. And then we move to the most important part of the program, which is the accommodation part. The accommodation part is sometimes summarized with this word, post-traumatic growth. Post-traumatic growth is what we need to change in our lives to incorporate all the important information that appears in cancer in our life: mortality, or the roles that I could or not maintain in my life, how people are around me, how can express or change or share my experience. People could understand me or not. Then in this part, there are also, in this part of accommodation, which are the main part of the program, 8 sessions are focused in this part. The first part is related with facilitation of post-traumatic growth. And here there are some techniques that we could discuss if you want, for not be too much longer. Yeah. And this is the most important part of this module. And after that, the last 2-3 sessions are focusing on existential and spiritual aspects, more related also with fear of recurrence. Well, fear of recurrence is work in all the other parts, but for example, we could anticipate a potential relapse and how we can deal with this. We can also discuss about positive models in these adverse situations. These are a kind of framework of the psychotherapy. It's thought with 8 to 12 group members.
And since we don't have too much time left for our interview, I have to admit that it's a tremendous work behind this project, because it seems very complex. As far as I know, it's unique in Europe in this way that you approach things, trying to take the patient in the past, in the future, to put it in the present. So you took it to all the stages, which is very important for a cancer patient to realize, to deal with, to confront itself, the others. So it is something really great that this program. As for the last question, if you can ask briefly, it is a statement within Psych-Oncologists that said that too much hope, it's a false hope. Do you agree? You don't agree?
Yeah, it's difficult to say yes or not, but I can understand that sometimes there is a hope that is a denial hope. No, if the hope is only focused in the disease, in survival, I think this hope sometimes could be, and it's too much hope. No? That could be a dysfunctional hope, no? Not false hope, but it's a dysfunctional hope. And sometimes when in situations that the hope of survival are compromised, for example, people who has advanced cancer or terminally cancers, we can broad hope if the hope is not only focused in survival and in the disease. Broad hope is related with how we can be engaged in our lives in these situations that perhaps life is not, it has a short time. No? And this kind of broad of hope is trying to be engaged with my people, trying to find relevant issues to do in each day, in each moment. And in realistic hope, normally we can find that the hope is really adaptive. In false hope, people normally are trying to avoid or deny what's happening around him, no? Because people who has a hope that is sustained with the people around them, there is people who normally are more adaptive. People who wants to be very with a high hope, but not talking about what's happening, trying to see only the desired future. Normally are people that the communication are too much rigid, and the way that share of experience in cancer is too much stereotypical. No? It's not a kind of flexible or
like a routine, for example.
Yeah, exactly. It's a kind of a rigid mantra that I have to say. If I'm going to be, I'm fighting every moment. I'm going to be cured. The people who doesn't contemplate other options normally are people that needs to be very monolithic in their ways of cope with cancer.
Dr. Ochoa, thank you very much for your ideas. Thank you very much for your thoughts. It was a wonderful discussions, and for sure, our audience, the patients especially, will find very interesting, and hopefully they will try to adapt or to apply some of your ideas. Thank you very much, and good luck further in your activity.
Thank you very much for your interest, Adrian, and for OncoDaily to give us the opportunity to explain something related to psych-oncology and these kind of positive psychotherapy treatments.
Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.